I'm Dr. Michael Miyasaki, and today what I want to do is I want to talk to you about getting out of the gray zone. Gray zone is kind of that area where we could be presented with a patient's problem, and it's just hard to figure out what to do or if we're going to do it. I consider that the gray zone. As we progress in our profession, we get more comfortable doing lots of different things. We'll pick out the things we like to do, and we'll kind of avoid the things we don't like to do. What I've been trying to do in these programs is just to present a lot of different ideas. We had some ideas on practice management. We had some ideas on occlusion. We had ideas on implants. We had ideas on root canals. We had even some restorative ideas that we presented. And if you've missed any of those, I encourage you to go back and re-listen to some or listen to them for the first time. Again, I'm just a general dentist doing all these things for my patients. And I enjoy learning new skills and learning how to provide different services to my patients. And I think that's one of the things that keeps this profession so exciting to me, where I don't want to ever stop practicing. And it makes my patients excited to come to our practice because they know we're always evolving. We're never going to do things the same way. We keep the good and what's working well for us and our patients. And we will learn some replacement techniques and use newer materials as the dental profession makes progress. We don't stay stuck where we were as the rest of the profession kind of advances forward. And I think dentistry today is so exciting because there's so many different things that we can get into. We can get into implants, aesthetics, periotherapy. I mean, there's just so many different aspects, and they have an impact on our patients' lives. If we do aesthetics, the patients' lives are improved. They have more confidence. They go out, they get better jobs, they sell their companies, they make a lot of money. I've had patients share so many positive experiences with me as we've just done smile design. When we treat TMD patients, we give them their lives back. I've had patients that are just crumbled masses. They come to us, they're in so much pain. They've been in so much pain for so long. They sit down in the chair and just start to cry because of that pain. We have patients that this presentation is going to be about is just they need a root canal. They have pain in a tooth. And when you can take care of that pain and restore that and give them back their life and their time, they're appreciative that you could do that. So I just want you to be excited about our profession. I want you to learn new things. And if you can do that, you'll never want to retire. You'll always have a good time providing patient care. And that's a really, I think, blessing that we have in this profession. It can be very, very rewarding in lots of different ways. So that's why I talk to different professionals as I go out and lecture, and there's just some that are undecided. What do they do with their careers, and what services should they provide? Which services should they learn? And I just encourage them, just make a decision. This profession is different for all of us. Some of us like to practice one way, some of us like to practice a different way. And the great thing about this profession that we've chosen is that we can all be happy having the type of practice that we want. So I encourage you to think about that, but let's get into this, getting out of the gray zone. So what is this going to be about? Well, getting out of the gray zone is today going to be about doing root canals and restorative work. Now, I'm a general dentist. Doing root canals isn't the most exciting thing for me. It's sometimes has been filled with trepidation, but over the last few years, I think I've figured out some really good things that now I feel pretty confident that when a patient shows up, we can diagnose, we can then perform the root canal and then restore. So I just want to go through this case with you. Think about patients maybe you've seen. I hope some of these things, a little light goes off. There's a little tip here or there you can pick up. If you've got some tips you can share with me, I'd love it if you send some of your comments back, and I could learn from this exchange of ideas. It's one of those things where when you put yourself out there and show how you handle the case, there's always going to be some people that will agree, some that will not agree, and some that will have the professionalism to say, hey, this is something that you might try next time you're in the situation. And I love that part because then we're sharing and I'm learning too. So here's a case that I just treated. 70-year-old female in good health shows up in our practice. Her chief complaint was that she had some growing discomfort in the lower right-hand side of her mouth. Tooth 29, the second bicuspid, had a large occlusal filling, so we call that the tooth 4-5 in the international numbering system. Tooth number 30, or the 4-6, You can see he had a large composite. That's the tooth in the center of our black and white image on the right hand side. And it also had an occlusal buccal composite in there, so it was a very large restoration. And then 231 or the 407 had a crown, and the crown had been there for a long, long time. So a patient comes in and just says this pain is for the last couple of weeks is intensifying. There's times where it's difficult for her to sleep, so she takes some over-the-counter medications to control it. But her concern is that it's going to get worse, and it just seems to be kind of snowballing, getting more and more intense. And so she wants us to figure out which tooth it is, and then figure out what kind of treatment is required. So in doing the interview, I asked her, is she having pain when she has something hot or cold to drink, or when she's eating, biting down on the tooth? And she says no, that she's really not having any issues in that way right now. So now I got to figure out, okay, which tooth it is, because she was telling me she was taking her fingers and kind of wiggling the teeth, trying to figure out which tooth it was. She thinks it is the first molar on the lower right-hand side, but she's not quite sure. So what do we do is I look at a radiograph that we've had, and I could tell in the radiograph that especially that lower first molar, the canals were just very thready, very thin. And then on tapped on the first bicuspid on the lower right-hand side, nothing unusual to the patient. Tapped on the second bicuspid, nothing unusual. Tapping on the first molar was a little bit more tender. Tapped on the second molar, 231 or the 47, nothing unusual. So I began to narrow it down to the first molar. The canals are very small and thready. It was a little bit more tender on tapping, but I wasn't sure when I was looking at that lower first molar that what you see down here on the bottom tooth, it had a large restoration. The margins are starting to break down. So maybe it was because the restoration was giving way, or maybe it's the tooth is flexing. So I took a tooth sleuth, which is a plastic instrument, kind of flat on one side, kind of tapered on in this case, the bottom side. And I would put the tapered part in the central groove area and ask the patient to bite down. I just let her know that, when you bite down, if it hurts, you can let up on the pressure. I don't want you to make it hurt, really bad, but I just want to see what the sensations are like. So I went through the first bicuspid, second bicuspid, first molar, second molar, and on biting in the central groove area, there was really no discomfort on either of those four teeth. So then I tried the different cusp tips. I'll put the tooth sleuth on the buccal cusp tip of the bicuspids, the lingual cusp. Then I'll go to the molars and hit the 5 different cusp tips on the first molar. Again, 231 or the second molar had a crown on it, so didn't really. I wasn't really testing the cusp on that tooth. But again, with the tooth sleuth and biting down, what I'm looking for is, is there biting or sensitivity on biting down, and then is there sensitivity when letting up? Because if the tooth has a fracture, many times when the patient actually lets the pressure up, that's when they're going to feel kind of a little pinch of in the nerve. But everything on the tooth sleuth was within normal responses. So then I wanted to figure out, well, maybe there was a fracture. That first molar, you can see, has very thin buccal wall of tooth and very thin lingual wall of tooth. Maybe there was a fracture in there, so I probed all the teeth, and all the probings were within normal 2 or 3 millimeters. So then we went and we did our cold test. Now, when I do the cold test, I've had one of these conversations with one of my associates. Now, I just use a long Q-tip, cotton swab, and I'll spray the end with my endo ice and put that on the tooth. And then my associate was taught to use a cotton pellet, and I think probably a cotton pellet is better on the end of a cotton plier because the cotton pellet can absorb more of the endo ice. So we went in there using the endo ice and Q-tip, or you could use a cotton pellet. And what I told the patient was, okay, now we're going to test the nerve. And what I want you to do is I'm going to put a little cold on the tooth. I'm going to have a little cold spray. I'm going to put that cold little Q-tip on the tooth. When you feel the sensation of the cold, please raise your hand. I'm going to remove the cold from the tooth and hold your hand up for as long as you feel that cold sensation. Because what I want to do is I want to see, one, does the patient feel it or not, or is it really intense? And then when I remove the cold from the tooth, how long does that sensation last? A normal tooth will be, okay, take the cold off, sensation just goes away within either immediately or within a few seconds. If we have a pulp that may not be healthy, one, they may not feel the cold at all because there's no nerve to sense the cold, or they may feel it in a delayed reaction. And when I remove the cold, it will persist for some time. So I put the cold on the first bicuspid. It tests normal. And I put the cold on. The patient raised her hand. It wasn't super intense, but she could feel that the cold was there. I removed the cold from the tooth, and she would put her hand down. So it was very transient. Went to the second bicuspid. She put her hand up when I put the cold on the tooth because she felt that cold sensation. I removed the cold, and she put her hand down when that sensation went away. Tooth number 30, I put the cold on, and she didn't raise her hand. And I held it there for a few seconds, and it was different than the first and second bicuspid. So then I went, and I didn't know if I was going to get any kind of reading off of the second molar because it had a crown on it. But I hit it with the Freon to get my little Q-tip really cold. I put it on that back crown, and she felt a little bit, so she raised her hand. I took the cold off, and she put her hand down. So it was normal on that one. The tooth that did not respond was that first molar. So I went back to that with my cold. I freshened up my endo ice on my Q-tip, and I put that on the buccal of the first molar, and I held it there. So it was about 2 seconds and 5 seconds, and right about 8 seconds, she raised her hand. So it was a delayed response. And then I removed the cold from the tooth, and it was slightly a little bit more lingering. So it was a very slow tooth to respond either way. I actually feel it and then have that sensation go away. So I told the patient that from all this, that the diagnosis that I thought would be that we had a necrotic pulp, that the nerve tissue wasn't responding well, that the thready canals just meant that we weren't getting enough blood supply to the nerves, and the nerves were kind of giving us these erratic testings, and that you're right, it was going to just continue to get worse. So the decision that I pose to you is, when you reflect on this, what would you do? Grab a cup of coffee now, grab a cup of tea, grab a bottle of water, whatever kind of calms you down, and sit down and microscopically look at this. What would you do? Are you thinking, do I or don't I do the root canal? And then the second question is, can I or can't I? Maybe you don't feel comfortable with doing root canals. And what I would urge you to do is, if you don't feel comfortable doing root canals, and you don't have to do the really hard ones, or you don't have to do the ones where you can't diagnose, feel comfortable with your diagnosis. But just reflect, what are the reasons why you don't do any root canals at all? If you did do root canals, and you could do them well, then that would benefit both the patient and your practice. Is one of the things that holds you back is you don't think you have the skills. Well, skills you can learn, and that's why I just love learning new things. And so when I didn't feel like I could do my root canals to the level that I wanted to, I have taken a lot of courses, listened to a lot of lectures to figure out, how do I do root canals better? I've taken the time. I've switched around with the file systems I've used over the last few years. I switched to a few different file systems to find one that I really liked and felt comfortable with. So I sat there and reflected. Root canals can be very difficult. I understand that. And even for me, I sat there and said, is that something that I want to learn how to do better, or do I want to refer them out? Today, I feel much more confident when I do root canals. I have a system. I have a protocol that I follow, and root canals are not easy to do. In the general practice, when I do a root canal, we have a cart for our endo specifically, with all the different files and irrigants and the motors and everything that we use. So we actually have an endo cart that we bring out. So it's not easy to do, but it can be something that can be very rewarding if you can do it in a predictable way. And that's what I want to show you now, kind of the way that I do these root canals. If you've been watching the last programs, what I like to do when I have a protocol, we're not just teaching about a material, but I have a protocol, is I try to give you the recipe. So the recipe is, first we have the diagnosis. In this case, I diagnosed that I thought the patient had a necrotic pulp. And then we talked about the necessary treatment. Well, you could do nothing, which I think is not going to be the great decision, because then the infection is going to develop in the bone, and then you could get some swelling and pain. Right now it's in the early stages. So I think if we treat it now, we can save the tooth and prevent a lot of discomfort. Then if we do the root canal, because this tooth has such a large filling in it, that we should consider doing a crown, because the crown is going to reinforce the tooth. Because once we do the root canal, we basically have hollowed it out. And if you bite down on something really hard, we run the risk of causing the cheek side and the tongue side of the tooth to separate or split open. And if the tooth does split vertically, then we can't save that tooth. We're going to have to extract the tooth and figure out something else to do. So the diagnosis was, I think we need to do a root canal. What's the necessary treatment? Root canal, maybe a core buildup, and a crown over the top. So when the patient comes in, we kind of reviewed this. I discussed her symptoms. We had the radiographs that we needed. We did the clinical tests as we discussed. Diagnosed that the lower right first molar had a necrotic pulp, and discussion of the treatments and the fees. So before the patient gets numbed up, we want the patient to understand what the cost is going to be, and what the total treatment of this tooth is going to be. It's going to be the root canal, the core, and the crown over the top. So now we've got the diagnosis, and we've got the patient understanding the treatment that's necessary, and we've got the agreement from the patient to proceed. Now that is a good part about where we are, is that I feel like I could do this root canal, and a patient's willing to go through the treatment. What we're able to do now is, and what I'm going to show you is, we're going to do the root canal, we're going to scan the tooth, we're going to fabricate the restoration, and within that 2-hour period, we're going to get everything done. We got the diagnosis, the endodontic procedure, and the restorative procedure done in one visit. Is it good for the patient? I think so. They get numbed up once. They get everything done, start to finish, in one appointment. Is it good for the practice? I think so. You got a lot done in a small window of time. Now I know, especially if it's an emergency patient, you're not going to have time to see all of these patients and do the one visit endo resto type of treatment, because you may not have time in your schedule. But when you have the time in the schedule, it's nice to be able to do everything. Now consider what you would have had to do. If you didn't do the root canal, what you do is you diagnose it. You have to then refer that patient to an endodontist. The patient has to go over to another office, perhaps on another day, has to get numbed up. Then they come back to you, hopefully within a couple weeks, so we can restore that tooth. They don't bite on anything between the endodontist and your office and crack the tooth, or they don't get lost. You know how time goes, where 3 years later they show up in your office and they bit down something and cracked the tooth, or the temporary filling came out and that tooth is now decayed. So the root canal did fine, it healed up, but now you can't restore the tooth because there's nothing to restore to. It's decayed subgingivally. And then the patient has to come back to you, and that's visit number 3 now, right? They came to you for the diagnosis. They went to the endodontist to get the root canal done, and maybe they got it done when they went there. Maybe the endodontist, his or her schedule was so constrained that they did their diagnosis and had to get the patient back to do the actual procedure. And then the patient has to go back to your practice. That's a lot of time versus if we can get it all done in one visit. So in the next portion of this video, we're going to go through how I did the endodontics and the restorative, just some simple tips, and give you the recipes to do that so that you might implement this into your practice. I think it's a good thing. So if you like these discussions, please hit subscribe. If you have any comments, things that maybe I could do better or things I could answer better, please put those in the comment section too. We're trying to create a community that you belong to, of a like-minded group of professionals that like to share ideas, that like to learn, that like to grow their practices by learning new skills. And if that's you, and I hope it is, then I welcome you to keep watching the videos, help me get better, and subscribe. So I'll see you next time, and we'll talk about how we did the endo and the resto. Take care. Thank you very much.